Thank you for inviting me. It's my pleasure to be here to give you the correct side of this debate. Those are my disclosures. None of this work has anything to do with high-flow nasal cannula. My objectives are to review the literature in relation to the use of high-flow nasal cannula to reduce the need for intubation, to convince you that random use of high-frequency, that's later's talk, high-flow nasal cannula may be deleterious to your patients, and most importantly, to convince you that my esteemed colleague is wrong. So I'm going to start with a case, pediatric ARDS. So here's a 12-year-old, previously healthy, presents to your PICU with a one-day history of worsening respiratory distress. Respiratory PCR shows that he has influenza type A, presumed bacterial superinfection based on the trajectory of his illness. He's breathing in the 50s. The saturations are 88% on a non-rebreather as he's admitted to your PICU from the emergency department. His moderately increased work of breathing. Cap refill is good, but the patient is tachycardic. At this point, his neurostatus is normal, although he's quite sleepy. By a show of hands, how many of you would put this patient on high-flow nasal cannula before moving to intubation? 1, 2, 3. Of course you would. So he's a fourth. Now, obviously, my goal here is to convince you, and as argue the topic as given or as we chose, is that high-flow nasal cannula is not an appropriate use for all patients prior to intubation. So I'm going to start with the classic article, and you have seen this. This article, New England Journal now, almost 15 years or so ago, argues that high-flow nasal cannula should be used and is beneficial in adult patients with ARDS. You've already seen these slides, is that over first 90 days of illness for these patients, that survival is in fact improved with high-flow nasal cannula compared to non-invasive ventilation or intubation. So with that, right, high-flow nasal cannula is a good idea, and we should be doing that, correct? Now, let's go through this in a little more detail. Cumulative incidence of intubation, exactly the same. Same percent of patients with high-flow nasal cannula were intubated as compared to non-invasive ventilation or standard therapy or standard oxygen therapy. So what's the take-home message of this study? Well, if you're an adult, maybe this difference at 90 days is significant. But for kids, let's think about this. There's no difference in intubation rates, but there's a difference in 90-day mortality. For pediatric ARDS, how many of our patients survive their acute illness, get through the first couple of weeks of ARDS, ICU stay, et cetera, and die 3 months later? We just don't see that in pediatrics. This is a very different population, and I would argue that this study actually does not apply to us. My esteemed colleague gave you a really nice, pure, clean definition of what high-flow nasal cannula is. I'll tell you that I'm not even sure what we're arguing. This is a study that was just published this past year in respiratory care. It's a survey of clinicians in the trenches, respiratory therapists in the US, and docs about what is high-flow nasal cannula. First question, really simple. How do you define high-flow nasal cannula? And look at this, all over the board. Some say that any heated humidified device with blended gas delivered by a nasal cannula is high flow, regardless of the flow rate. Others define this based on the inspiratory demand, patient's inspiratory demand, others based on set thresholds, either weight or age-based, but all over the place. Which method is used to set flow? Sometimes by provider order, sometimes by protocol, sometimes by weight. We really have no idea how we're defining high flow. How do you adjust the flow rate? Again, as you see this, clinicians at the bedside doing this work cannot agree. Nor can they agree what you do when the patient's oxygenation is below goal. Do you increase the FiO2? Do you increase the flow rate? No standardization in approach whatsoever, regardless of the questions asked. So I would argue at this point that we're not even sure what high-flow nasal cannula is in a given patient. Everyone is doing this quite differently. Also of interest here in the last question, what do you do when high-flow nasal cannula fails? Only 7% go on to intubation. That makes me wonder how many patients in this cohort are actually on high flow that probably don't need any support. And we're seeing that in our ICU, in our cardiac ICU specifically. I'm not saying this is correct. It is so rare to see one of our cardiac babies extubate and not be put on high flow just because, just to prevent reintubation. I think we're way exceeding the need for this therapy. So the conclusion here, there's no consensus on the definition of high flow or how to make adjustments, and the definition really needs to be standardized. Okay, with that, let's move on. A lot of studies on this topic, lots of variation. One of the key things about almost all of these studies is that there's significant faults in these studies. What you'll see here is a meta-analysis published in 2017 in Respiratory Care. Throughout these 9 studies, all of them have concerns over blinding. You can't blind a study. You know whether the patient's on regular oxygen therapy, high flow, or non-invasive. Intrinsically, you can't do it. There's other issues here of blinding in terms of outcome assessment. It's very subjective whether you intubate a patient or not. As much as you want to really have objective criteria for failure, there's a great deal of subjectivity here. And on. You can see throughout this whole slide numerous problems with all of these studies, regardless of the perspective that you take. And this is going to be true of all the studies that Dr. Schibler presented and all the ones that I'm going to present here. But if we go on and we look at the data of the meta-analysis, I'm not sure if everyone here is used to looking at forest plots, but with the forest plot, if the black diamond hits the center line of unity, then there's not a statistically significant finding. And you'll see in every slide that I show you, there's no statistically significant findings throughout all these meta-analyses. So first comparison here, need for invasive mechanical ventilation, high flow nasal cannula versus non-invasive, no difference. High flow nasal cannula versus standard oxygen therapy, no difference. Mortality, high flow versus non-invasive, again, no difference. These are adult patients. I'll show you one more adult study before moving on to the pediatric literature. Another meta-analysis in adults, slightly different studies included here, but in terms of the need to escalate support with standard oxygen therapy versus high flow, again, no difference at all. Again, in this study, or in this meta-analysis, in red there, significant problems with blinding in all of the studies presented. So what if we go on to pediatrics? Let's look at bronchiolitis, the area where we have the most data. Recently published study here, again, comparing on the top high flow nasal cannula versus standard oxygen therapy, and then the bottom versus CPAP. Length of stay shown in this graph, again, no difference whatsoever. If we now move on to length of O2 therapy, again on the top, high flow versus standard oxygen therapy. On the bottom, high flow versus CPAP, no difference. And lastly, need for ICU transfer, again, no difference in any of these studies. Throughout this meta-analysis, again, as shown in red here, problems with blinding in all the studies, and numerous other confounding variables or problems, as shown there in yellow, in terms of blinding of outcomes, selection bias, and others, multiple problems throughout all of these reports. Okay, let's go on to the Treadmill study here, looking at high flow nasal cannula versus CPAP. Again, clearly a pediatric-based study in intensive care medicine. What do we see in this case? Regardless of the outcome measure, whether you're looking at the modified Woods clinical asthma score, respiratory rate, or any of the other outcomes, there's no improvement with high flow nasal cannula, and in fact, CPAP is shown to be superior. Treatment failures, notably higher in the high flow nasal cannula group, as shown in red on the top, compared to the CPAP group here, shown in blue. One of the specific points I want to make on this study is right here at 1 hour, what we see is treatment failure showing as early as 60 minutes after start. Keep that point in mind. I'm going to come back to it here in a couple more slides. I'm going to take a big jump here, and this is a really important point. So this is not a pediatric high-flow nasal cannula study. This is actually an adult-based, non-invasive study looking at adults who were extubated, developed respiratory distress, and who were managed with either BiPAP or standard therapy. The reason I show you this here is that in both groups, the reintubation rate for these adults is about 50%, no difference. Look at the difference in mortality, though. The non-invasive ventilation group had a significantly higher mortality, almost twice as high as compared to standard therapy. Well, why is that? The time to reintubation. The non-invasive ventilation patients went 12 hours before being reintubated, whereas the standard group, 2.5 hours. So I argue that in all these therapies, whether this is an adult NIV study or pediatric patients that we randomly apply high-flow nasal cannula, often when you give a therapy and you really have this bias, assumption that the patient's gonna get better, and you wait too long to truly definitively intervene, badness happens. With that, the last couple of slides here are all gonna stress the same point. And the point here is, if you are gonna disagree with me, if you are gonna go ahead and try high flow in all your patients, keep in mind that you have 1 to 2 hours to make a decision, no longer. This publication here, looking at the pediatric early warning score, what they showed was that at 90 minutes, you can tell whether a patient was gonna succeed or fail. Do not go beyond that time frame. This is an asthma study, pediatric ED asthma study, that did show benefits to high flow. Very different population, but I show you this slide in this study because, again, here on the bottom, right there, 2 hours, that within 2 hours, they can determine success versus failure. So if you are going to use this therapy and you go down the approach, when it doesn't work, if it doesn't work, admit defeat quickly and do not compromise your patient. So why not just try high flow? It's simple, it's benign, it's easy. Well, there's no generally accepted escalation and de-escalation algorithms. I argue that we shouldn't be trying high-flow nasal cannula for everyone. That seems to occur in some units to facilitate extubation, again, our cardiac unit. But you can prolong the ICU length of stay and potentially hospital length of stay by giving therapies that are not needed. It's expensive, not per patient, but expensive when summated over the course of all the patients that we're talking about, especially if length of stay is increased. In some areas, it may interfere with feeding. That really is unit and provider specific. And then again, there are real risks of delaying intubation for those who really do need it. Last study that I'm going to show you, this is a study of a cohort of pediatric bone marrow stem cell transplantation patients, very specific population. But I show you that because those patients in this cohort that received non-invasive ventilation prior to intubation had a significantly higher mortality rate than those who didn't. Delaying the inevitable, delaying intubation when it was needed, was in fact harmful. We saw that in that adult study. We're seeing that in this pediatric study as well. So as my time runs out, I've got 2 minutes for 2 slides. I will show you here that in a study that is much more applicable to this debate, in the first ABC study here, looking at high-flow nasal cannula versus standard therapy here, CPAP groups. What we see on the last line here is that high-flow nasal cannula patients experienced fewer ventilator-free days. So those high-flow nasal cannula patients, more of them converted to a higher level of support, and those patients in the end had fewer ventilator-free days when intubated than those patients that were intubated outright. So delaying the inevitable can increase mortality and can also increase length of stay and have bad outcomes for our patients. So with that, I'm going to argue that a trial of high-flow nasal cannula should not be routinely offered before intubation. It may be, and I will acknowledge the argument that you heard earlier, that it might be a reasonable approach for those with more mild lung injury, although it may be prolonging the length of hospitalization for our patients. However, as lung injury becomes severe, the risks increase and are real and can be bad. Do a PubMed and you simply put in high-flow nasal cannula and pediatric ARDS, you come up with 0, nothing at all. There are no data to support a routine trial of high-flow nasal cannula prior to intubation. The studies that are available are generally small, biased, and non-conclusive. If high-flow nasal cannula is attempted and clinical improvement is not seen within 1 to 2 hours or the patient worsens, transition to non-invasive ventilation may be or intubate and admit failure. And I would say that we can argue that point, and we will continue to argue the point of high flow versus not, but I think this piece that you really have 1 to 2 hours to make a decision is real, and I'd be welcome to debate on that, but I don't think there is much. And with that, I'll conclude and look forward to the rebuttal. Thank you.